Okay, it's noon. Let's see who I was missing this morning. Elizabeth Mitchell, did she come in?
Yeah, I'm here.
Okay. You're just when I missed this morning. Okay. So we talked about anaphylaxis and anaphylactic shock this morning, which is a form of impaired tissue perfusion due to an antibody antigen reaction. But there are other types of type 1 reactions that are not anaphylactic, which are still antigen antibody reactions, but they are not anaphylactic. So these are just your typical allergies. So you might have that the antigen bound with your mast cells in your nose. So you might get hay fever type of symptoms. And so, you get watery eyes and runny nose and sneezing and that type of thing. Or maybe with your skin and you get a rash and itching and that type of thing. So you might get symptoms, but not the bronchial constriction and the hypotension and the laryngeal edema that is associated with anaphylaxis. So you can have plain allergies that are not anaphylactic. That's just symptomatic in the area that you tend to have them. So type 1 is some type of antibody antigen reaction that causes the release of histamines. Now, a type 2 reaction is a cytotoxic or a cytolytic reaction. This is where there's a binding with the antibodies on the cell wall, and this causes the cell wall to rupture. Now, this is a hemolytic reaction such that you get when you get the wrong type of blood. So when you get the wrong type of blood, it's a type 2 antibody antigen reaction, and you get the hemolysis of the cells, and that's what causes the kidneys to plug with all those ruptured cells that's happening. And so a blood transfusion reaction, a true ABO incompatibility, you got the wrong blood type, is a cytolytic reaction. However, you can get an allergic reaction you could be allergic to some of the antibodies that are you could have an antibody antigen reaction to something that's in the blood. So you can get the itching and the rash, but not the kidneys plugging up. In that case, it's a type 1 reaction, but the true getting the wrong blood is a type 2 reaction. And that's where the cell walls burst and they plug up the kidneys. There are some drugs, we don't give these drugs hardly anymore at all, but there are some drugs that will cause a hemolytic reaction. The most common kind for that is horse serum. Before we got tetanus toxoids, we used to have to give horse serum for tetanus before my time. But you'll have people that say especially older people will say they're allergic to horse serum. And so if you have to say horse serum, what in the world is that? That used to be what they gave to prevent tetanus. And so people had problems with that afterwards. I'm sorry, I didn't mean to do that. So you might have problems with that, but typically it's the type 2 cytolytic reactions are due to getting the wrong kind of blood. The type 3 is a immune complex reaction. And this is where you get an antibody and antigen reaction that is so tiny that the antibodies can't find it and eat it. And you learned about, probably the first one you learned of this was in 152 when you learned glomerular nephritis. And this is where the strep and the antibody formed, and they hooked together and they circulated and they landed in the glomerulus and they started eating the glomerulus away. And so this is what happens with glomerular nephritis. We often see this in rheumatoid arthritis where it lands in there and it starts to injure the joint in rheumatoid arthritis. And it is also what is the causative agent in systemic lupus erythematosus, but it often is a autoimmune. And so it's seeing itself, but it's a tiny, tiny little complex and it's really hard to treat. So we're going to talk about lupus next because you really haven't had any classes about lupus. So it's systemic lupus erythematosus. It's abbreviated SLE, and most people just call it lupus rather than systemic lupus erythematosus, which is the official name. Now, lupus is a long-term chronic condition, and it is a multi-system condition. It can affect any system in the body where that little tiny complex lands. As you'll see in a minute, we'll talk about the most common places that it typically lands, but it is multi-system. It can land anywhere in the body. So it's not just a specific place that it tends to land. And so, but it tends to be antibodies that land that have reacted to their own RNA or their own DNA. And it also can be just red blood cells and platelets. So it's just, you're kind of having an allergic reaction, a type 3 complex reaction to your own cells. It is an autoimmune disorder. Now, because it's kind of your own cells all the time, you're sort of in an immunodeficient state all the time. You're sort of fighting off infection. You're immunosuppressant all the time when you have lupus. My daughter was recently diagnosed with lupus, and every time she has blood work about every 2 months, she calls me because I'm always real concerned about her white count, because her white count, she's always fighting infections, and she can't produce as much white counts because she's immunosuppressed, and her white count got down to 2. And that very much concerned me. And she said, "Oh, the doctor said that wasn't bad." And I'm thinking to myself, to me, that's bad. But I guess if you're immunosuppressed and you're always going to have a low white count, I guess that wasn't a horrible white count. She's back up to 3.9, and I'm thrilled with that. But still, to me, that's still on the low side. But if you're immunosuppressed and you're always fighting an antibody antigen, or even though the antigen is yourself, if you're always fighting it, you're always using up your white cells. You're always using them up. And so your white count is going to be low. So you typically will go into remission where you might not be having a lot of symptoms, or you will go into exacerbation. And there are things that tend to trigger exacerbation, trigger symptoms. And these triggers are pretty much across the board. We know there are things that tend to trigger exacerbations. And one of the things are certain drugs. Now, I'm going to put, I will tell you what these drugs are, but I'm going to start with oral contraceptives. And I'm going to add pregnancy, which is not a drug, but I'm going to put pregnancy up with this. Oral contraceptives and pregnancy are probably the 2 most common things that cause or trigger, not cause it, trigger lupus. The reason is lupus is typically diagnosed, it's more commonly seen in women, not only women, but more commonly seen in women than men. And it first raises its ugly head in the childbearing ages. So you put oral contraceptives and pregnancy together, and what do you get? Hormones. Hormonal changes tend to cause exacerbation of lupus. So that's why we get the first symptoms with their first pregnancy, because that is when we get this huge shift of hormones, is when they're first pregnant. And that's when they start having this pain. And then birth control pills are also associated because that is a hormonal contraceptive. Other drugs that tend to cause this is isoniazid. Now, isoniazid is abbreviated INH. And if you remember, that is the prototype. That is the drug that's used for the treatment for tuberculosis. So almost everybody that has tuberculosis will be put on isoniazid plus another drug. Another one that tends to cause it is hydralazine. Now, hydralazine is for blood pressure. It's a drug of choice for blood. It's not a drug of choice. It's a drug that can be used to lower people's blood pressure, and it tends to cause exacerbation. So if somebody with lupus also is hypertensive, hydralazine would not be the drug of choice for lowering that person's blood pressure. So oral contraceptives and isoniazid and hydralazine are not the best drugs to give these people because we know that they tend to cause exacerbation. Stress. Again, medical stress is more than physiologic stress. So after surgery, they often go into exacerbation. After a major illness, they might. And psychological stress can bring this on. My daughter's biggest issue, hers was really diagnosed and brought on by COVID. She's a hypochondriac anyway. I don't know, it's not a diagnosed hypochondriac, it's a mother diagnosed hypochondriac. But she just knew she was going to die from COVID. And she, with all of her other little symptoms and the internet, she knew she was going to die from COVID. And I kept saying, would you be quiet? Get over this. Come on. Because I'm probably the least hypochondriac, least germaphobe you've ever met in your life. You can eat your boogers. I don't care. You can wallow in the dirt. I don't care. I'm the least germaphobe that ever walked the face of this earth. And so, I'm just like, get over it. And so, but she was so stressed and it almost paralyzed her. And finally they diagnosed her with lupus, but mental stress brought this on for her. Environmental pollutants, smog, hay, things in the environment will tend to bring on lupus. This one is very, very much, very absolute. Exposure to UV light. What's UV light? Sunshine. Now, you don't have to become a vampire, where all you can go out is at night and you have to stay in the house in the daytime. You do not have to do that. But you need to wear a hat. You need to wear gauzy long sleeves. You're not going to be a sun bunny anymore. You're not going to lay out in the sun anymore and get a tan. You want a tan? Go get a spray on tan. You can't go to a tanning booth because that's UV light. You got to wear sunscreen and protect yourself from UV light. Overexposure to UV light can cause exacerbation of your lupus, along with X-ray exposure. Probably just getting an X-ray of your ankle, getting an X-ray of your wrist won't do it. But like if you're a major trauma victim and you get a lot of X-ray exposure, it can trigger your lupus. So what are the symptoms? So we want people to know what are typical triggers and how to avoid them. They need to avoid the sun. They need to wear a hat. They need to use sunscreen. Oh, and I miss viral infections. Bacterial infections usually don't cause it, but getting the flu, getting a virus. What's COVID? It's a virus. You might get a mild case of COVID, but it might make your lupus flare up. Okay, so what are the symptoms? Here they are. Generalized, these kind of happen to everybody. They'll usually run a fever, weight loss, arthralgia. They'll have myalgia and arthralgia. So, their joints hurt, their muscles hurt. Excessive fatigue. They can hardly get out of bed. They are so tired. They can hardly get out of bed. And then, depending on what body system is involved, where did that little complex land, they will have symptoms of that body system. So what is the most common body system where it lands? 85% of all people with lupus, it will be in the musculoskeletal system. And they will say they are so stiff they cannot get out of bed in the mornings. They cannot walk. I mean, my daughter could not raise herself up off the toilet. She could not get out of bed. Forget getting in a bathtub. She said, if I got in a bathtub, I would never get out of a bathtub, ever. She said if she got up in the middle of the night to go to the bathroom, she'd have to call her husband to help lift her off the toilet because she was that stiff. She said every muscle. My daughter lost almost 70 pounds because her mouth would not open. Because her jaw and her TMJs in her mouth was so tight that she could not open her mouth to chew. So very arthritic joint symptoms is the number one, 85%. It is musculoskeletal. And this is what sends them to the doctor. They cannot move. She started with her hands. Her hands were swollen and she said there is no way that she couldn't open a bottle of any kind. Even if it had been already opened for her, even if you'd already opened this Coke bottle for her, she could not screw the lid off of a Coke. Her joints would not move enough to let her screw a lid off of a Coke. So it's just myalgia and arthralgia is the number one complaint. And this is during exacerbation. During remission, they can pretty much do whatever they want to do. About 50%, only about half, will have skin symptoms. And they will have the erythematotic rash, the red rash on their face, their neck, and their extremities. Everywhere the sun touches, they will tend to be very red and splotchy in those areas. And they might develop a butterfly rash across their face. And this girl, you can see her butterfly rash. Here's the wings coming across her nose, and then the wings again over here. Much of a butterfly rash. Now, a lot of people go to the doctor because they get this red rash on their face and they think they have lupus. But only about 50% of the people have a butterfly rash. Only about 50% of the people have skin symptoms. They also have alopecia, where their hair falls out. I'm going to use my daughter again for an example. My daughter, who has thick hair, when she would put her hair in a ponytail, her ponytail would be at least this big around. She'd have to have one of those big ponytails. When she came to see me in July, because she lives in Texas, I would say her hair might have been enough to hold into this as big around as this pencil. I mean, she basically had lost almost all of her hair. She was almost bald from her lupus. But when she finally got out of it, and her hair is coming back. When you're not in exacerbation, you will get your hair back. But she lost extremes about. She said, "Mom, my hair is coming out in handfuls." She said, "I'm trying not to brush it. I'm trying not to wash it," which is like what we tell people in chemo. She said, "But my hair," she said, "you would not believe the amount of hair that is coming out of me." She said, every time I brush my hair, I can almost feel a plastic grocery bag of hair. But she had a lot to lose, but still. So alopecia is very, very common with this also. So luckily, skin or muscle and skin, even though you're in extreme pain and you may have the rash that goes along with it, that's what most people have. And it is extremely, extremely painful, extremely. But it's usually not life-threatening. However, if this little complex lands in your heart, lands in your lungs, or lands in your kidneys, typically you will have a shortened lifespan because you're going to develop heart problems. It can get in your valves and you can have valvular disease. You can develop pericarditis. You can develop endocarditis. If it's in your lungs, you'll have pleurisy, pain with every breath. Your pulmonary function studies will decrease. So you won't be able to suck in as much wind. Your tidal volume is going to drop. With renal, you can have renal failure, and that renal failure will not go away. You will end up on dialysis because of it. So they're always watching your renal system very, very close. They're constantly doing EKGs on you. They're constantly doing x-rays, even though they want to watch the amount of x-ray exposure you have. But every 2 months, you get a chest x-ray. You get an EKG, lab work watching your renal function, because they want to make sure that complex is not getting there into your renal or heart or lungs. So people that get heart, lung, and renal involvement do not tend to live as long as people that are skin and muscles. People with skin and muscles typically live a normal lifespan. Heart, lung, and kidneys don't typically live a normal lifespan. So it all depends on where it lands. How can you prevent it landing one place to another? You can't. It all depends on where it lands. If it lands in your brain, in your central nervous system, in your brain, you will only about 15% lands in the brain, and those will have seizures, and they will be put on an anti-seizure medicine like phenytoin. During exacerbation, they will develop organic brain syndrome. Most people don't know what organic brain syndrome is. I put it here because you might see that term on NCLEX, and when I used it, people were like, huh? I don't know what that is. Organic brain syndrome is just a fancy word for dementia. So while they're exacerbated, they might get confused. But typically during remission, they are very, they do fine. They have no problems. They're very alert and oriented. They have no problems during remission. But exacerbation, they can be very confused during exacerbation.
Janie, I have a question.
Sure.
How long are these periods for people? Like, I'm sure everyone's different, but like ballpark, is it weeks, months, just days?
Most people are 3 to 4 weeks. But if it's your heart, and once you have heart damage or kidney damage, those last forever.
Okay, thank you.
Janie, and another quick question. Will the complex, are there multiple complexes that land in multiple places? Like, can you have musculoskeletal and renal symptoms?
Absolutely. Absolutely.
Okay.
And of course, the more symptoms you have involved, the worse you are. Okay. It can affect your hematological system. And so you'll typically, kind of like my daughter, you're going to have probably some anemia. You'll probably have mild leukopenia, might have thrombocytopenia, but quite often, especially during exacerbation, you're going to have a low white count because it's constantly trying to fight the immune response, constantly. And so you might see that. You also will have what they call your inflammatory markers are going to be up. It's like your SED rate, your ESR, your SED rate is showing inflammation somewhere in the body. It's not telling you where in the body it is, but your inflammatory markers are going to be up. And there's other more involved tests that they can do that show inflammation in the body. So whatever your doctor is using to show inflammation in your body, your inflammatory markers will be up during exacerbation. During remission, your inflammatory markers are going to be down. Typically, they use a SED rate and a C-reactive protein. Those are the two things they use the most that show inflammation in the body. You're in increased susceptibility, mostly because your white cells are always being used up. So you want to not be exposed to a lot of infection. You got to watch what you're doing. You got to take care not to go around people that are sick, because you probably don't have the best white count in the world. If your lungs are involved, you're very, very at risk for pneumonia. And this is often a major cause of death. Pneumonia is a major cause of death for people that have lung involvement, cardiopulmonary involvement, heart and lung involvement. Pneumonia often kills these people. Lupus is very, very hard to diagnose. It's getting better. It used to take about 10 years to diagnose lupus. And there still is not a definite test that says, I'm going to run this test, and if it comes back positive, you have lupus. There's really not a test for that. There's tests that are better about saying, we're pretty sure you have lupus. But most of the time, what they do is you have symptoms and they do tests. They've got better tests that say you don't have lupus. But then if you don't pass those, well, you might have lupus. And so they keep running tests and they rule out lupus. And when they get to tests where they can't rule it out anymore, they will say, well, you meet enough markers that you have lupus. And so there's different places use different numbers, but let's just say there's 10 markers that are typically seen in the patient with markers. Most people say if you have 5 of the 10 markers, you will be diagnosed with lupus. Like it's an anti-DNA, an anti-RNA, a C-reactive protein up, a SED rate up, a positive ANA, all these different tests, but you don't have to be positive in all of them. But if you've got 5 of the 10, some people say 4 of the 10. It's all depending on what your rheumatologist wants to, what they consider it. But typically, once you hit a certain number of markers and you're positive, they will now say that you have lupus. But there's not a test that says, I'm going to run this one test and it will say that you have lupus. It's kind of the whole picture. And so it takes quite a while. But they do have tests that say if you don't have this positive test, you absolutely do not have lupus. And basically what it is it shows that you do not have an autoimmune disorder. So if you pass that you do not have an autoimmune disorder, then you do not have lupus. So a lot of people go in because they get a rash on their face and they'll run this test. It's called an ANA, an anti-nucleotide assay. And it'll come back negative and they'll say you do not have lupus. If it comes back positive, they'll say, well, you have an autoimmune disorder. We're just not sure what kind yet. Could it be Sjögren's? Could it be lupus? Could it be something else that we don't know yet? We don't know. But it's some kind of autoimmune. We've got to do more testing. But there's no one test that says you have lupus. Okay, so now we think you have lupus. You've got enough markers and your history and your presentation is enough to maybe think you do. So what do? They try to start mild, depending on your amount of symptoms, and work their way up. So they'll start with NSAIDs. It's an inflammatory response, so let's start with an anti-inflammatory. When my daughter's first presentation was her hands, NSAIDs worked great for her. She loved the NSAIDs, and she thought they worked great for her. However, they didn't want her on them long because they're hard on the kidneys. And they said, we don't want your kidneys to be damaged, so we will let you use them for a little while, but not for a long time. You cannot be on long-term NSAIDs. They're too hard on the kidneys. So you can't do that. But it helped for short term. It helped her get over her initial hand problems, okay? When she could not move at all, they moved her up to steroids. She went on steroids for a while, and that helped her. And of course, as you know, she had all the symptoms of being on steroids: the moon face, the bump flow hump, the weight gain, the change in her personality, the I don't know if they tested her blood sugar. I'm sure they did. The hyperglycemia, all the things that you know that Jane talked about with Cushing syndrome or Cushing disease. And then, of course, as you know, you must always wean people off of steroids. You cannot stop steroids cold turkey. Never. Ever. You must always wean, because you will throw them into cardiovascular collapse if you don't, because of that fluid volume excess will just go. It's like pulling the plug on a balloon or pulling the plug on a swimming pool. Just your veins, your blood vessels will just collapse right on down. You've got to let it out slowly and let your normal tone take over. If that doesn't help, they're going to have to go into some type of other therapies. Some will go into the hydroxychloroquine. They thought, remember, this is what they all thought was going to cure or prevent COVID. Do y'all remember this? And they were really concerned because everybody that was on taking it for lupus was having difficulty getting their drugs, because all of a sudden they were using it as a preventive for COVID. But then they found out it did not prevent COVID. but they were using it for a lot of people with lupus. Now, this is what my daughter takes now. And she says she's not quite ready to say it is a miracle drug, but for her, it has been a miracle drug. She went on it last March. She's been on it since March, and she has had no exacerbation of any kind since March, since she's gone on her hydroxychloroquine. None. She says, my hands are perfect. My feet are perfect. Her hair's grown back. She has absolutely no pain since she went on it. A friend of hers that has lupus said she might as well take water. It didn't help her one bit. Well, my daughter says it's a miracle drug. So her friend has had to go on to an immunosuppressant, a chemotherapeutic drug. She has to suppress hers even more because that one didn't work for her. So she was either on cytotoxin, methotrexate, or Imuran, and these are the generic names right in front of you. But you may probably have heard the trade names. So she's been on a chemo drug, and they seem to be working for her, but she's having all the side effects of taking chemo. But she can get out of bed. She can walk. She's not in constant pain anymore. Antimalarials are really good for skin problems, not just SLE, not just lupus, but things like eczema, psoriasis, and any type of skin problems. The same if you have bad lupus skin problems. And of course, this is your quinine-based drugs. And so you think, well, malaria, we don't really have much malaria in the United States. Why are we giving antimalarials? You will find that your antimalarials are given to people with skin problems, and they work really, really well. So people that have, like, you'll see people with psoriasis that take antimalarial drugs that have a quinine base in them. And it's not because they have malaria. They don't have malaria, but it works well on skin. Your antimalarials do. Now, about 2 editions back in Lewis, under lupus, there was a huge section about plasmapheresis and how plasmapheresis was going to be sort of the treatment, the end all to be all for lupus. So what is plasmapheresis? Well, it's done in a dialysis setting. And pretty much, and I'm simplifying this so much, but pretty much what they would do is you would run through a thing that looked like a dialysis machine, and it would take out your blood, and it would screen out the antibodies and then put your blood back in you. And this is an antibody-antigen reaction, and these antibodies are attacking your own body, which is your antigens. So let's screen out the antibodies in dialysis or in plasmapheresis, and then you won't have an antibody-antigen reaction. And it had pages and pages in Lewis. And I would talk about plasmapheresis and the nursing care of plasmapheresis in this section. And then the next edition of Lewis comes and it says, might use plasmapheresis. I'm like, well, what happened to these pages and pages of plasmapheresis? And of course, when I go back and we look at evidence-based practice, they found, well, maybe plasmapheresis really didn't work like they thought plasmapheresis was going to work. Well, at that time, when I kind of said this same thing I'm saying now, a girl in the class raises her hand. She says, I work at a dialysis center, one of the ones out in town. She said, I would say half of every patient of our patients that come to our dialysis center are lupus patients, and they're there for their plasmapheresis 3 times a week. And I said, well, and that just kind of goes to show you that they're getting success and they're getting plasmapheresis. So it may not be listed as a treatment of choice, but there's still probably plenty of people that are having success or having relief of some of their symptoms by getting plasmapheresis. So plasmapheresis says it might be used, it might not be used. It's not really seen as a number one treatment of choice at this point in time. So let's go back to some nursing diagnosis. Well, pain. It was myalgia, arthralgia was the number one in 85%. It was joint discomfort and decreased mobility. So our goal is that the patient will have decreased amount of pain. So if they need pain medicine, NSAIDs will help it. Just getting rid of the inflammation will help their pain. So they might need analgesics. They're not typically put on narcotics. The key is to get rid of the causative to decrease the inflammation, thereby helping their pain. Rest. Don't overwork their joints. Let them have their rest periods. These people should not really be exercising a lot. And plus they're fatigued terribly. They like temperature extremes. If they want hot packs, put hot packs on it. If they want cold packs, put cold packs. They don't really like midstreams. They like the extreme of the temperature. It seems to help them. About 50% like hot, about 50% like cold. What is the preference of the patient? It doesn't matter which one. Protect their joints. Again, they should be, if the joint's inflamed, then put it in a sling. Don't overwork an inflamed joint. We got to get the inflammation down. Don't overwork it. And then just non-pharmacological measures, whether it's music, whether it is something that's diversion, what will help? Pet therapy, I don't know, whatever helps non-pharmacological, aromatherapy, music therapy, whatever's helpful to help decrease pain, whatever would do that. The rash, impaired skin integrity, they're going to have urticaria, so they got the itching, the alopecia. They want to keep the skin clean and dry. When they are in remission, they can use whatever they want on their skin. When they're in exacerbation, they will probably be on a prescribed ointment during exacerbation. When it's really itching, when the skin might have breakdown on it, they should not be using over-the-counter when they are in exacerbation. When they are in remission, over-the-counter is fine. They should avoid the direct sunlight. Like I said, they should wear hats when they're out, because it can trigger an exacerbation. They need to wear sunscreen anytime they are exposed to the sun. They should learn to wear clothes that are gauzy, very thin, but still long sleeve. So no tube tops, no t-shirts that expose their arms and that type of thing. And assist them with their body image. I know hair loss was a big thing for my daughter. It was huge. So here's this little lady, and it's usually a lady, but it can be men. But we see it much more in women, and we see it more in dark-skinned women than we do light-skinned women. But it can be light-skinned women. But it tends to be more in dark-skinned women. Now, my daughter's very light-skinned, but it can be. It's usually darker-skinned women than light-skinned. And so this woman has a erythromatic, a red rash wherever the sun, I'm pointing on the wrong screen. She has a red rash wherever the sun is she comes in contact with, and she has a butterfly rash. But remember, that's only in about 50% of the cases. Almost everyone gets weight loss during periods of exacerbation, extreme fatigue, a low-grade fever, not high-grade, a low-grade fever, arthritis and myalgia, emotional lability. They get very emotional. They cry a lot. Their white counts tend to drop because they're always fighting this immune response, and they can get neurological disorders if it affects their central nervous system. And the worst case scenarios is going to be when it affects their lungs, and they're going to have shortness of breath, pleural effusions, pleurisy with pain, decreased tidal volumes. If it affects their heart, They're going to get vascular inflammations. So they're going to get vascular disease. They're going to have murmurs. They're going to have pericardial friction rubs and effusions. They might have to have a pericardial centesis or a pericardial window put in, or they're going to get pericardial tamponades. And they can develop renal failure because of this. And they'll have to be on dialysis for the rest of their life. These things do not go away. Typically, when it gets lung, heart, and kidney, it does not go away. So it can be pretty mild to devastating. However, the mild ones have usually a normal lifespan. The devastating ones do not. Okay. The next section is on HIV and AIDS. And believe it or not, you have not had a lecture on HIV and AIDS in the whole time you've been in school. This is going to be your first HIV and AIDS lecture. You've had plenty of exposure, and I'm sure plenty of courses have talked about care in general, very specific about their population group. But about HIV and AIDS in particular, this is going to be your very first lecture. But you've heard about it. You've been exposed to it many, many, many times. Now, acquired immunodeficiency syndrome is AIDS. It's abbreviated AIDS. Acquired immunodeficiency syndrome. It is a chronic, progressive immune disorder. And it is caused by the human immunodeficiency virus. HIV is the virus that causes acquired immunodeficiency syndrome. HIV and AIDS are not the same thing, but people tend to call them the same thing. They are not, but they often are used as synonyms. HIV is when you have the virus. AIDS is when you have the disease. And those are two entirely different things. You're contagious with both of them, but they are two entirely different things. Now, I went to nursing school in the late 70s. Okay, I graduated. Yeah, I know most of you weren't born. I graduated in 1978. And I can honestly say that when I went to nursing school, I call it the dark ages, but it wasn't the dark ages. We pretty much had everything that you have. We had intra-aortic balloon pumps. We had ventilators, just the MAs, just like you all have. We had chest tube drainage systems with the 3 ports, just like you had. Yes, we had bottles too, but we were moving. Okay. We were moving into, you want this? Oh, okay. All right. I'm online. I'm sorry. That's my son. We were moving into the 3 chest tube bottle system and leaving the bottles. We had Swan-Ganz catheters. I mean, we had everything that you pretty much had. We had LVADs. We had just the same stuff you do. But we didn't have AIDS. The first case of AIDS that I remember was 1981. What is this? I don't know what this is. And it was typically seen in homosexual white men. That was the highest population group. And it was a disease that most of them did not want their families to know they had, because they hadn't really told their family that they were homosexual. And they would come into the hospital. It was almost always respiratory. They had PCP pneumonia, which we're going to talk about. And so we didn't know how to treat it. And so we would chemically paralyze them, put them on the ventilator, thinking if we let their lungs rest, they would get better. But they ended up dying. And we would tell their family they died of lung cancer. They didn't have lung cancer, but they didn't want their families to know, so we told them they died of lung cancer. So the first case of AIDS that I remember was 1981, but the first documented case of AIDS is 1959. And it was a British sailor. And so the people have known, scientists knew about AIDS for quite a while, but they just didn't know a lot about AIDS. but I remember 1981 as the first case. So when I went to nursing school, I tell this story often. I love to tell the story because it's so funny now, but at the time it wasn't funny at all. But you would have a box of clean gloves that probably it took at least 6 months to go through to get through a set of clean gloves. Because the only time you wore clean gloves, was to take old dressings out of a patient's belly or off a patient so that your bacteria on your hands didn't get inside of the patient. So you would take out old dressings and then you would put on sterile gloves to put in new dressings. So when I was a little nursing student, and I was little. I used to be skinny, believe it or not. I was a tiny little thing, little cheerleader. I was little long blonde hair. I was little tiny thing. And my maiden name was Vickers. Okay. So, of course, when at that time in nursing school, they called you by your last name and you had your little cap on your head. God knows you had to wear your cap because that made you a nurse. That's why I'm so against caps because, I fought so many years to get that cap off my head. So if y'all want to wear caps, you're going to wear them clinical if you're going to wear them. Okay. So anyway, I've got this patient and I was a little shy. Believe it or not, I was a very shy nursing student. And so I'm walking down the hall and I have a towel and a washcloth and I have a pair of gloves and everything. And I'm walking down the hall and my nursing instructor says, Miss Vickers. Yes. Where are you going? I said, I've got to go to my patient's room. He's had a bowel movement. I'm going to clean him up. She says, Miss Vickers. Yes, ma'am. Yes, ma'am. I have a question for you. Yes, ma'am. Yes, ma'am. Do you wear gloves to wipe your butt? No, ma'am. Then why would you insult your patient by wearing gloves to wipe his? Oh, no, ma'am. I would never do that. I am so sorry. I would never do that. So I immediately put my gloves back down into that clean glove box because that's the way it was taught. We didn't wear gloves. So things were a little different then. But universal precautions came about because we learned there were disease-carrying blood-borne pathogens. So everyone's blood became contaminated once AIDS came about. And we treated all as contaminated. And then they changed the name to standard precautions, from universal precautions to standard precautions. And then it became common that we would wear gloves. So, when you all are my age and you're teaching nursing, maybe, and your students say to you, you didn't wear bubble suits in nursing school, and you say, we wear gloves. They're going to think you're as backwoods as you all think. I was backwoods. But, things grow. As you learn and evidence-based practice and evidence-based research comes along, you learn more and more and more. So AIDS came about. But the thing about AIDS is you can't see it from the outside. Towards the end, you can tell quite often, but who's HIV positive in this picture? It could be all of them. It could be none of them. It could be some of them. You cannot tell from the outside who is HIV positive, who has AIDS, and who doesn't. This is Bernard. He has AIDS. But I should not treat Bernard any different than I treat any other patient. I should not treat anyone in this picture any different than any other patient. Every patient you care for has AIDS and HIV as far as you are concerned. That is what standard precautions is. Therefore, and this is very important, you do not treat any patient different than the next patient. If you don't treat the AIDS patient any different than any other patient. Every patient is as if they have AIDS. So whether you have that diagnosis on a piece of paper or not, you treat every patient the same. If you don't use a plastic fork to feed a patient, every patient, then you don't use a plastic fork to feed an AIDS patient. AIDS isn't carried by saliva. It's not in the mouth. So an AIDS patient does not need a plastic fork. They don't need a disposable fork. If you don't, I hope you don't do this. And I know there's nursing instructors that have you do it, and it's wrong. And if you answer it on NCLEX, it's definitely wrong. If you don't double glove for every single patient, but you do for an AIDS patient, it's a wrong answer. Every patient is treated the same. If you need to double glove, then you need to double glove for every single patient you take care of, because every patient has AIDS. You don't know who has AIDS and who doesn't have AIDS. How do you know I don't have AIDS? I've been exposed for 40 some years. You don't know if I have AIDS or not. You don't know. If you don't wear well, now with COVID we do, but if you don't wear a mask in every single patient's room you walk in pre-COVID, then you don't wear a mask in an AIDS patient's room. The AIDS patient doesn't have anything that is transmittable by air to you. Nothing. That is very, very, very important. Okay. All right, y'all, it's 12:51. I'm going to see y'all back here at 101, and we're going to use the last 50 minutes talking about AIDS. Okay. I'll see you at 101. I'll stay online if anybody has any questions.
Janie, this isn't really a question, but how's your daughter doing with her lupus diagnosis? My sister also has lupus, and I have a lot of cousins who have it.
My daughter is doing exceptionally well. She was pitiful. And it was right during COVID when she got it. And I am such an enabling mother. I am a big enabler, especially with my son. In fact, I'm in Charlotte right now babysitting, which is why I'm here. I'm going home tomorrow morning because I got to stop in Waynesboro and get my second vaccine shot, or I'd go home tonight. He just got in from New York. He just flew in. That's why I came to the door. But I was here babysitting. But she called me. It must have been March. It could have been February. I'm not sure. My phone rang about 3 o'clock in the morning, which is very odd. And it was her. And I thought, man, what's she calling me for? And I picked up the phone, and she was crying. She said, she called me mommy, which is very unusual for her to call me mommy. But she said, mommy, please come to me. Please come to me. You've got to come to me, mommy. Of course, I'm in the middle. The preceptorship, it must have been March, because the preceptorship had just started. And I said, Terry, I can't. She said, mommy, please, you've got to come. And I'm thinking, number one, the airlines are closed. There's no way I can get on a plane tonight or tomorrow morning and get to you. There's no planes in the air. By the time I drive to Texas, what am I going to do with the preceptorship? I've got students on at night. I visit you all 7 days a week, pretty much. Not always, but pretty much. 12 hours a day. I'm on 12 hours a day, 7 days a week for 6 weeks in a row.
Wow.
I'm dead on my feet anyway, but I can't get away. I mean, if I said to Jane Benetti, Jane, I have to go to Texas, I'm gone. Jane Benetti would say to me, go. I will cover. I will do I will work 24 hours a day for you, Janie. That is how great Jane and I work together. But I would never do that to Jane. But I know if I had to leave right this minute, Jane Benetti would cover for me whatever it is I need covered. But I said, Terry, I can't come. And to this day, she still says, I needed you so badly, and you did not come to me.
Oh.
And that makes me sad. I mean, it makes me really sad.
I'm sure. I know that Terry's a mom. I'm a mom too, so I can imagine.
I mean, she's 36.
Yeah. But they're still your babies. Doesn't matter how old they get.
Yeah. But anyway, she's doing really, really well. And her kids were upstairs. Now her kids they're 10 and 8. So they were probably 9 and 7 at the time. But she could not go upstairs. But her husband's a really exercise freak.
Mhm.
And he's a nice guy. I like her husband, and he provides very well for them. And but his answer was, you need to get out of bed and exercise. Your problem is you're not exercising. Well, she couldn't do anything. She couldn't get out of bed. She was dropping weight like everything. And of course, it was COVID, so her kids weren't in school. She said, at least if the kids had been in school, she maybe could have gotten to school. The school was less than a mile away. Could have gotten to school and come home and gone back to bed. But the kids are home. The husband's home, but he's in his office all day because of COVID, saying, I can't watch the kids. I've got to be on conference calls in Hong Kong and blah, 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 blah. And it was just horrible. It was just absolutely horrible. And she said, I need you here. And I'm thinking, I can't get there. Or I'm thinking, if it's next year, I'll be retired in July. I have to be on a plane, or I have to be in that car, and I drive 20 miles, 20 hours, I'd be there.
Yeah.
But it's just the way it is. But once she got better. Once her markers came down and she could move, and she decided she wasn't going to die from COVID. And she's just now going out of her house for the first time.
Well,
Just now.
yeah.
Just lately. She has never been to the grocery store ever.
Oh, wow.
She either does Instacart or she picks it up. They put it in the trunk of her, in the back of her minivan.
Maybe that's been good with, feeling so bad she didn't need to get a virus or COVID or anything on top of it, or that added stress.
But she did go to, I think she had to go in Target the other day, and she was just like, oh my God, Mom, I went in Target. And she said, I triple masked. She said, I had 3 masks on my face. And she said, all I could do was keep saying, oh, you all are so crazy. There was one reason, I can't remember why she had to go to Target, but she had to go to Target. And she's just like, I cannot believe I went in Target. But she's actually getting out of the house more now. She's actually starting to go out and do some things. But since the meds, she's doing well. She's been pain free for months now.
Good.
And her white count, she's felt better since her white count. She's 3.9. And she can tell. She says, since my white count's gone up, I feel so much better.
That's good. That's good.
Yeah, it's tough.
Yeah, my sister just recently had an exacerbation, and it's attacking her liver. And it had already been attacking her kidneys. She has like chronic kidney issues because of it. And now it was attacking her liver. And I was trying to explain to her, some of the other things that she sees going on. She's bruising really easily and, all this stuff. She was like, but what does that have to do with my liver? And I was like showing her notes, and I was like, look, I'm studying it right now. Here you go.
Probably okay. Did you tell her vegetables? Did you tell her that? She needs vegetables? Okay.
Yeah, I was going over everything, and she kept trying to dismiss me. I was like, no, seriously. This all has to do with your liver.
Listen, as I tell my child who went to pick up his little one, because I had to drop his little one off really early this morning because I said I have to be back by 9 o'clock. I tell my son I'm the smartest person I know. But it's amazing to me because my husband thinks I don't know a single thing about healthcare. He thinks I am as dumb as dirt about healthcare. And I say, Michael, you've got to do this. You've got to eat this, or you got to don't eat this, or do this. He'll say, you don't know anything about healthcare. What are you talking about? You know what? I think my students think I'm smart. If you think I'm dumb as dirt.
Yeah, I think y'all are all very smart, very knowledgeable.
I think, you don't think I know anything, do you? He says, well, I don't think so. I'm like, oh, God.
Yeah. I know you're learning stuff. I know you know a little bit of stuff, and I'm like, no, trust me, I can show you.
What do you think I'm reading? I said, I read the textbook. He said, why are you always reading that textbook? I said, this is my student's textbook. It's a new edition. I got to read what it says, so I'm telling them what it says. He says, I don't know why you do that. I said, you don't just think I just sit there and say, oh, well, I think I'll just talk. I guess he thinks I'm an idiot. I don't know. The husband doesn't think I'm very smart.
I'm sure he thinks
smart either. So
they don't appreciate how much we learn in nursing school and with your years of experience and everything.
It's so funny.
It's a lot you learn.
He can't, but he's so mad because I drew up all the insulin. My dog, the diabetic dog, I drew up all our insulin. So I had all these syringes drawn up with the right amount of units. And then I left them in a place. I said, okay, now you have to give Zoe her shots. And He's so mad that he has to give her these shots. He thinks that's terrible. Too bad. So when I told him I wasn't coming home till tomorrow, he's like, that's 2 more shots I have to give her. I said, hey, too bad. So sad. I drew them up.
Okay.
You could, at least I drew up so I know she get the right dose.
Yeah.
You're going to have to stick her. That's terrible. I said, hey, not that terrible. You're okay.
No.
But I didn't plan to be here. So I got my vaccine at Anson in Wadesboro. Because at least it was like an hour less than coming into Charlotte to drive from the beach. So my second shot's at Wadesboro in the morning. I thought, well, if I drive home tonight after I'm done teaching, that's 3.5 hours to the beach, then 2.5 hours back in the morning, then 2.5 hours back to the beach. I might as well just wait and go in the morning and just stop at Anson, get my shot, and then drive on to the beach. I thought, that's stupid. I'll just wait.
Yeah.
I'll just stay here and drive home in the morning.
Jamie, I have a
There's
quick
a test
question.
on Thursday for somebody. I'm not sure who's taking a test on Thursday. Someone has a test on Thursday. Who else is talking?
Sorry, I have a quick question really quick. For lupus, I know anti-malarials are used for treatment for skin problems. Did you say that hydrochloroquine is the anti-malarial?
No. Hydrochloroquine is used for lupus. It's for the symptoms of lupus.
Okay,
Helps with the
so not just for the
inflammation.
skin.
I'm not exactly what classification hydrochloroquine is. Let me look it up. I'm not sure what
I
it
looked it up and it said it was an anti-malarial. That's why I was just confused.
anti-malarial.
is. Anti-malarial?
I think it is.
Yes.
Okay, well then, but it's not really for the skin though, but a lot of your anti-malarials are for the skin.
Okay.
Oh, it
that
really,
makes sense.
it's an anti-malarial. Okay, I don't think I knew that. Okay, good. Thank you for letting me. I'll say that the next class will know that because I'll say that.
Perfect. Perfect.
But it's really
Thank
not for
you.
the skin. I mean, it might help the skin, but we don't give it because of the skin. It just really helps their symptoms. So it's an
Okay.
anti-malarial. I did not know that. Okay, good. Thank you.
Makes sense. Thank you.
Okay, so let's go on with HIV and AIDS. It's 101. So when we're talking about HIV and AIDS, just a little pathophys, because we always got to talk about what's happening in the body. HIV is the virus. It is the virus that causes AIDS. So it is a retrovirus. All that means is it replicates backwards. That's all it means. And in this picture here, it kind of shows what an HIV virus looks like. And it has these little knobs on it. And if y'all remember, when COVID first started, COVID has little knobs on it. And that was one of the reasons why COVID was so virulent, is because of these little knobs. Because at the bottom here, your cell membrane has these little receptors on them. And so when you have a virus that has these little knobs on it, they go into these little receptors really, really easy. And that's what makes them so contagious or so virulent. And so they hook onto your cell membrane, and then they go in, and then the virus can then go into your cell. They kind of merge together. So that's why it sort of makes it easy. And then it replicates backwards, which doesn't make it that bad. It's just called a retrovirus. That's just all that it means. It just replicates backwards. So we give them a retroviral drug. And so it's actually a very, very fragile virus. This just kind of shows what in the different cells, this kind of big clump here just is what you're looking at here. But it's a very, very fragile virus that attacks your CD4 cells. Remember that your CD4 cells are your helper cells. They're the ones that secrete the antibodies that fight things, not just infections, but viruses and tumors and all sorts of kind of things. And so that is what that HIV attacks. It attacks your CD4 cells. Now, your normal CD4 count is 800 to 1200. So if you have a CD4 count between 800 and 1200, you probably are fighting things pretty well. If you drop down between 500 and 800, you might have just not feeling well. Maybe you feel like you're sick. You kind of kept a cold all season, or you just seem like you haven't been feeling as well, but you don't really have these major issues going on. You just kind of say, I think I'm going to make a doctor's appointment. I just haven't been feeling real good lately or feeling well lately. But it's not something that you can necessarily put your finger on. Like maybe it seems like you have a lot of diarrhea, or maybe you just seem like you've been having night sweats, or you just seem like you've had a nagging just a little cough, not a bad cough, just a little naggy cough or something, just little minor problems that I think it's time for me a checkup, that kind of thing. But if your CD4 count gets less than 500, you will feel sick. You will actually say, I am sick, when your CD4 count gets less than 500. So we can draw CD4 counts and kind of follow progression on how you're doing when you get HIV. How is it attacking your body? And if it's destroying more and more of your CD4 cells, we know that you're getting worse, that you're getting more virus in your blood. Or we can just measure how much virus is in your blood, and that's called your viral load. The more virus you have in your blood, the higher your viral load. The lower you have in your blood, the lower the viral load. So there's many different ways. Some doctors like to look at CD4 counts. Some doctors like to look at viral load. It's all whatever the doctor wants you to look at. So those are just some of the things that we look at. I say this is a fragile virus. I didn't finish this. Outside the body, it only lives about 6 seconds outside of the body. Or as long as it is not, if it's wet. When it dries, it's dead. But if it's wet, it can live a little longer when it's wet. Okay. So if you have like a dried bloody spot on the side rail of a bed, there's no HIV in that dried bloody spot. It has to be wet or it's dead. It's a very fragile virus outside of the body. Now, inside the body, it's pretty virulent, but outside the body, it's pretty fragile. These are some of the nursing diagnoses we're going to look at: risk for altered health maintenance, diarrhea, altered mucous membranes, and some of the psychosocial issues that might be affiliated with this. Well, so risk for altered health maintenance. One of the biggest keys for HIV is don't get it. How can we teach people about transmission? Who gets it? How do you get it? What are the methods of transmission? All of that's very, very important because people have misconceptions about how you get it. The most common method of transmission is still unprotected sex with somebody that has the HIV infection. They don't have to have AIDS. They have to have the HIV infection. And it is the highest population group is still homosexual encounters with an HIV partner, somebody that has HIV. Next comes heterosexual with somebody that has HIV. Those two are the most common, homosexual first, then heterosexual. You can get it from contaminated blood products still. As you know, with other things, and Jane talked about hepatitis and that type of thing, there are good blood banks and there are bad blood banks out there. And so there are ones that don't screen their blood like they say they're going to screen their bloods. So contaminated blood products can still be a problem. Hemophiliacs that have to get lots and lots and lots and lots and lots of blood products throughout their lifetime, they are at higher risk. Sharing of IV needles is a problem. And mother to child transfer is a problem. So these are some of the most common risks that we see about this. So people need to, education is still very common because sexual contact is important because sexual contact is still the most common form of transmission. HIV is found in blood, semen, vaginal secretions, cerebrospinal fluid, and breast milk. It is not transmitted by casual contact. It is, you do not find HIV in tears, sweat, saliva, urine, feces, sputum, or in insects. That doesn't mean you don't want gloves on when you touch feces, but There is no HIV in feces. There is no HIV in sputum. There is no HIV in sweat. That is why I sort of get these. I'm not going to correct you, but I always wonder why you all have gloves on when you do your physical assessments. I know in 101 they tell you to put gloves on. It drives me up a wall. What do you think you're going to get? I mean, if they got lice, I guess I would have gloves on for lice. If they had poison ivy, I would have gloves on. But what do you think you're going to catch? And I want to know, can you feel temperature through those gloves? The answer is no. And I'm telling you, no. And if you think I believe that you're feeling the pedal pulse with your gloves on, I almost would tell you on a little old person with a fractured hip that you do not feel that pulse. And I could tell you a story, but I probably don't have time to tell it. But my point becomes, I won't correct you because your practice is your practice. But what do you think you're going to catch? Now, you're going to put your hand in their vagina? I'd have a glove on. You're going to touch their semen? I'd have a glove on. You're going to touch their blood? I'd have a glove on. And if I'm going to touch their poop or their pee or their spit, I'd have a glove on. If I'm going to touch a body fluid, I'd have a glove on. But skin doesn't require a glove. Feeding a patient doesn't require a glove. Washing a patient's face doesn't require a glove. Pretty much giving a bath doesn't require a glove. Unless you're washing a butt. I haven't figured it out yet. Now, that's my own personal preference. But assessment, I'd like to know that you're feeling something. And it's hard to feel with a glove on. I'm telling you, it's hard to feel. Okay. Typically, a patient is contagious about 1 to 2 days after they have been exposed. So if you have sex with an unprotected person, you will be contagious. You will have HIV in your bloodstream in about 1 to 2 days. So you will have it, and it will last throughout your entire lifetime. There is no cure for AIDS or HIV at this point in time. So how do we prevent it? Well, abstinence. Well, you can just about forget that. It's not going to happen. And I'm not a proponent of abstinence either. But I am a proponent of condoms. Ladies, if your partner says, oh, it just doesn't feel natural. Well, first of all, get a new partner. Second of all, get yourself a vaginal condom. It inserts a lot like a diaphragm, and too bad, so sad. I'd get myself a new partner is what I would do. And no IV drugs. Those are your highest risk there. That's all there is. Okay, so when you go getting exposed, there are stages getting to AIDS. The first 2 stages, you are called HIV positive. It means you have the virus in your bloodstream, but you do not have the disease of AIDS. The first one is called an acute infection, and it used to be called the acute retroviral syndrome. But now it's been changed to acute infection, but it's the acute stage. And this was usually, you will see symptoms at about 2 to 4 weeks after infection. Now, you're contagious at 1 day, 1 to 2 days, but you won't feel sick for about 2 weeks. Even though you're contagious those 2 weeks, you won't feel sick for about 2 weeks. And so in about 2 to 4 weeks, you will have the worst case of flu you've ever had. High fever, malaise, arthralgia, headache, nausea, vomiting, diarrhea, rash. You will have a bad case of the flu. This flu will last for about 2 weeks. Then that flu will go away and you will feel fine. So most of us do not go to the doctor when we have the flu. We say, oh my God, I got the worst case of flu. You'll treat it symptomatically. And you know what they say about a cold and the flu? If you treat it, it'll go away in 2 weeks. If you don't treat it, it'll go away in 14 days. Okay. So, in about 14 days or 2 weeks, the symptoms will go away and you will feel fine. Unbeknownst to you that you are actually in an acute infection stage or the acute retroviral stage. So do you know that you have HIV? No, you do not. And you're passing it around. So you'll go into stage 2, which is the asymptomatic infection. And it used to be called the latency phase, but now it's called the asymptomatic infection. This will last for about 10 years. Again, you are asymptomatic, but you are infectious. So you are passing it around and you have no symptoms. So you didn't get tested in your first 2 weeks because you thought you had the flu. And now you're 10 years asymptomatic. So you're passing it around for 10 years. At the end of that 10 years-ish, 10-year-ish, your CD4 count will get between that 500 and 800, and you might start feeling a little yucky, and you might go to the doctor, but you might not. But toward the end of the asymptomatic phase is when you start to have some symptoms. Then, like I said before, your CD4 count will probably drop less than 500, and this is where people go to the doctor, and the doctor says, well, just to be on the safe side, let's draw an HIV test on you. Because your symptoms are more than just vague. You probably are having diarrhea all the time. You're probably having persistent fevers. You're probably just feeling like dog do all the time. And so you actually end up at the doctor. So you're starting to have, at the end of that asymptomatic phase, asymptomatic infection, you're starting to have some symptoms. And it's because your CD4 count is less than 500. And so then you get your test. That's typically where we see the test done. Then you're going to go into the third stage. The third stage is when you are diagnosed with having the disease. And that is called AIDS, acquired immunodeficiency syndrome. Now, this is defined, the disease is defined by the Center for Disease Control in Atlanta. It's if you ever want to go to the CDC website, cdc.gov, and go to, I think it's under the different diseases, and go to HIV and AIDS, there's some great slides about what part of the country has the highest rate, what age groups have the highest rate, the homosexual with the partner, the heterosexual with the partner. It has races, it has everything. The highest population in the country is in the Southeast where we live. It's the highest AIDS in the United States. The lowest AIDS is in the Pacific Islands. I mean, it has very, very interesting data in there. And it's data. I didn't make it up. It's data that the Center for Disease Control collects. So I used to present the slides, and people would get angry with me because I was stereotyping people. And I'd say, well, I didn't make it up. It's from the Center for Disease Control, and people would just kill me on evaluations about my slides, and I was being mean to people, and I'm like, well, I don't have to show the slides. You all go look it up yourself for the Center for Disease Control, and you can write letters to the Center for Disease Control then. But they're really kind of interesting on what age groups, what population groups, where do we see the most, who's getting AIDS in the United States. It's kind of interesting. All right, so the Center for Disease Control has said, what makes you move into the diagnosis of AIDS? In order to have AIDS and not just be HIV positive, you have to have one criteria, just one. Now, that criteria has to start with the phrase, if you are HIV positive and you have one of the following, you now have AIDS. If you're not HIV positive and you have one of these, you don't have AIDS. You have to be HIV positive and have one of the following. So one of them is that your CD4 count is less than 200. That means you have AIDS. if you're HIV positive and your CD4 count's less than 200. If you're HIV positive and you develop one of the opportunistic infections that the CDC has outlined, what does that mean? It means your body has allowed an infection to come about that usually we don't get. Usually we fight it off. But your immune system is compromised and it's given it the opportunity to develop. And I put some of the most common here, but there's a huge list on the CDC website. These are not all inclusive by any means. You can have an opportunistic infection and have a normal CD4 count. You only have to have one HIV positive and one criteria. So don't think you have to have a low CD4 count. Most do, but you don't have to. Okay, so you can have a fungal opportunistic infection. You can have a viral opportunistic infection. You can have a protozoa opportunistic infection. You can have a bacterial, a pneumocystis, or a bacterial opportunistic infection. So let's look at some of these opportunistic infections. And when you get an opportunistic infection, you treat them as if it was just an opportunistic infection. We don't treat the AIDS patient any different than we do any other patient. So opportunistic fungal infections. By far the most common is probably candidiasis, which is thrush. If you've never seen thrush, I know there's always a glare in the pictures. It is a white, flaky looking thing on the tongue and maybe the roof of the mouth. You can even see it back here on the uvula and the tonsils back here. So this is candidiasis, this is thrush. So, babies get thrush all the time. Do they have AIDS? No. You have to be HIV positive and develop candidiasis. Then you have AIDS. So just because you have thrush doesn't mean you have AIDS, but if you're HIV positive and you get thrush, you do. So how do we treat it? We treat it with an antifungal drug, the most common being fluconazole. Fluconazole is the generic, diflucan is the trade name for fluconazole, but we would treat it with an antifungal. Another antifungal is amphotericin. Amphotericin B is antifungal. It's a lot stronger, tends to cause pancreatitis if you're not careful about it. Cryptococcal meningitis is another one. If you get cryptococcal meningitis, you got AIDS. Histoplasmosis is a fungal. Aspergillus, I think it's Gilius. I might be pronouncing that wrong, is another one. So if they develop a fungal infection, a yeast infection in their vagina, if they develop a fungal infection and they're HIV positive, they now have AIDS. They have the opportunistic infection of AIDS. Oh, I went backwards. I'm so sorry. Viral infections, probably the most common is cytomegalovirus, which is CMV. You can get it anywhere, esophagus, stomatitis, colitis, pneumonias, anywhere. One of the most common that we see is CMV retinitis. So when they look in the retina, your retina should be nice and round. So you can see this retina is not round. It sort of has all these little splotches all in it. And so these patients are going to have decreased vision. And so they're going to have problems with going blind before they die. And I've had several patients, even as students, I've had students have had these patients. And the ophthalmologist will come in and inject an antiviral into the patient's eyeball, trying to clear up this retinitis in the hopes that the patient doesn't go blind. So retinitis is usually a problem with vision type thing. Another virus that we see real often is shingles and herpes simplex. Now so if you get herpes simplex, not everybody has AIDS, but if you're HIV positive and you get herpes simplex and you have AIDS, not everybody with shingles has AIDS, but if you're HIV positive and you get shingles. crying in there? Stop it. Okay, sorry. Okay, so this is herpes simplex right here, if you've never seen it. This right here, you can see they got these lesions just kind of all over the body, the little cracked, little pustule looking lesions. If you've never seen shingles, this is a great picture of shingles. Remember, shingles does not cross the midline. So notice it's only on one side of the body. And it's hard to see in this picture, but there's little pustules that run along this. And so this would go right around, and it'll go around to their backside, around to their spine, and then it's going to come back around. It'll go along their dermatomes. It'll go right back here. It'll go around to the back. It'll come right back here and come back here. And there's little pustules that run right around this, and that's exactly what shingles looks like. It does not cross the midline of the body, of the body. Shingles is only on one side of the body, and it runs in a line. This doesn't look in a line, but if you were up close and could see this picture, you would see the pustules that run in a little line right across there. But herpes simplex is anywhere on the body. It does not run in a line. So these people would probably be put on some kind of antiretroviral, and they usually have VIR, V-I-R in the name, like a acyclovir, ganciclovir. Usually VIR is an antiviral. Another one is hairy leukoplakia. If you've never seen hairy leukoplakia, some of you all have hairy leukoplakia, and that's ulcers around in their mouth. And so here you go. Look at this big old ulcer right here. Look at this big old ulcer behind their front teeth right here. The mouth is one of the dirtiest places in your body. And so they get some infection or some, and this is typically viral. Most of the time, this is a virus. This is not bacteria. And they get these horrible lesions on the side of their tongues. You know, we get a little canker sore, a little bub, and we're like, well, look at these horrible things in these people's mouths. Just terrible. And so they need some kind of a viral ointment type thing that's put in their mouth. One of the most common ones that we see people come in is pneumocystis in their lungs. That is viral. And it's called pneumocystis carinii or pneumocystis. And this next word you see up here is PJP is pronounced Yerovitsi, is how that's pronounced. Yerovitsi, kind of like the sandwich gyro. Like it's not a gyro, it's a gyro. Pneumocystis Yerovitsi. We call it PCP pneumonia for pneumocystis carinii or PJP pneumonia for Yerovitsi. They're the same thing. They were just named two different things, okay? And they are very common. Many patients come in with that. Now, this is a normal lung. This lung is nice and black as air, gray as tissue, and white as fluid. Now look at this little pebbling, little tiny pebble looking action here is classic of pneumocystis. This is not contagious. There is pneumocystis floating in this air. Every breath I take has pneumocystis in it. But I don't colonize it because I have an intact immune system. But the patient with AIDS cannot fight it. And so they start to colonize pneumocystis, and they get these little pebbly things in their alveoli, and that blocks gas exchange. So these patients will come in, and I see this in the ER a lot. I'll have patients, you know, they're about 26 years old to 36 years old. And what they'll come in with cough and shortness of breath. And they will send them around for a chest x-ray, and their chest x-ray will come back looking like this. So what happened? They were exposed when they were around 16, 17, 18 years old, or in their 20s. They've been asymptomatic, the name's changed, asymptomatic infection for about 10 years. So now they're in their late 20s, 26, 27. Now they have AIDS. They have no idea that they've been positive for the last 10 years. They come in and this is what their chest x-ray looks like. And we have to tell them that they have AIDS because they have the opportunistic faith. Yes, we're going to draw an AIDS test on them, but an HIV test on them, but they have pneumocystis pneumonia. This is not contagious. We do not treat an AIDS patient any different than we do any other patient. They are not in respiratory isolation. And I know there's a question on NCLEX about this, because there's a question about a patient with PCP pneumonia and their family wants to come visit. What's important for the nurse to tell the family? And it's like, you must wear a mask every time you go in the room. There's no need for a mask, that their pneumonia is not contagious, and a couple other things. And what a student years ago failed the NCLEX exam, and she called me yelling at me, screaming at me that I never taught her anything about this. And I said, I'll beg your pardon about that one. I will let you know that I most certainly did talk about this, that PCP is not contagious, and you do not treat an AIDS patient any different than you do any other patient. About well, I know COVID's a little different now, but the only pneumonia that we really and truly isolate is meningococcal. Do you put your patient with pneumonia on isolation? No. When your patient gets pneumonia on a ventilator, do you isolate them? No. We don't isolate pneumonia. Meningococcal, we do. When they got meningitis pneumonia from meningitis, we do, but we don't isolate pneumonia. It's not contagious. It's not contagious. Pneumonia is not contagious. So we're not going to catch PCP pneumonia from AIDS patients. Tuberculosis. Now that's a bacteria.
Hey, Janie, I do have a question.
Sure.
Just going back to like the mask thing, this might be like a stupid question, but wouldn't you want the family members to wear a mask just for like the protection of the patient, like to protect them from the visitors?
No, they are not in immunocompromised protection because they are not going to get better.
Okay.
Immunocompromise is for someone who we've knocked out their white count, like a cancer patient, while we rebuild up their white count. So we put them in strict isolation. This patient, a patient with AIDS, is going to progressively get worse until they die. So if you bring them in and put them in immunocompromised isolation, what did you do? Go to your room. You may not come out of your room. You may not have basically any visitors, and everybody that comes in your room has to wear mask, glove, booties, helmet, bonnet, face shield, everything, but you can't go out of your room. And if you are brought out of your room, you have to have a mask on, and you can have minimal visitors. Now, 2 days later, they're ready to go home. We open the door and say, all right, bye. Go back to your normal lifestyle. I mean, it doesn't make sense. I mean, in reality, there's nothing that's going to protect them. Their life says that they're going to keep going downhill over the next 2 years until they die. So why isolate them? There's no need to isolate them.
Okay.
Okay. Now, this is tuberculosis, which is a bacteria. And we treat it with antibiotics. It's not a viral. It's not virus. Pneumocystis we can treat with antivirals, and maybe we can help them, but usually they get too hypoxic. Now, this is lung. This is lung. This is scars. So when you hear we're looking for cavitation, this is scars. This is the cavitation right here. This is lung. This is okay. This is the bad. This is where the tissue has just been eaten away by tuberculosis. So people with tuberculosis don't have AIDS, but if you're HIV positive and you get tuberculosis, you have AIDS. Okay. And of course, we treat this with anti-tuberculin drugs. Isoniazid, INH, or with rifampin, or any of the other ones. They're all antibiotics. I can't think what they are right this minute. They get a lot of skin problems with this. They can have opportunistic cancers, the most common being Kaposi sarcoma. This is an example of Kaposi sarcoma. It's a waxy, and it's usually a purple or a yellow waxy type of cancer. It's a skin cancer. but they get it kind of all over their body, or they can get it even isolated places. They get a lot of invasive cervical cancers, or they can get lymphomas. All of those are opportunistic, not cancer, or it's not a disease, but if they have more than 10% of their ideal body mass is gone, or they become demented, confused, they now have AIDS. So here's another Kaposi sarcoma on this guy's nose. It's just kind of a waxy looking type of lesion. That's Kaposi sarcoma. This is Kaposi sarcoma again, purple, waxy looking lesions. Here's one in his eyeball. This is lymphoma. This is that cervical neck lymph node I was talking about. So your lymph nodes become very hot and inflamed. So this is right on this. This is lymphoma. So you treat lymphoma with chemotherapy. We would treat them with chemotherapy. The Kaposi sarcoma, they typically treat with chemo also. They don't usually remove those. They usually just give them some chemo if they can. If it's real extensive, they won't treat it at all. But this is lymphoma. They would treat this guy just like they would with anybody with lymphoma, with some type of chemo that would work for that.
Miss Janie, can I ask you a question?
Yeah.
One of my aunts had HIV/AIDS, and she had developed like sores all on her face. Is that the Kaposi sarcoma?
It could be very readily. Could be, yes.
Okay,
Could be.
because it didn't look flat and waxy, but they were like, I don't know, like different kind of dark looking sores.
They get a lot of skin lesions. A lot of skin lesions. They're very common with AIDS patients. But you know, they probably have to biopsy them to know for sure. I can't answer it, but it could be. Doesn't have to be. That's massive. That's cachexia right there. Look at that body wasting. Wow, that's pretty good, huh?
Janie,
And
can I
then-
ask you a question?
Sure.
When it comes to the lesions, I know that this is only really transmitted via like the blood, semen, and vaginal secretions. If they have a lesion that is open, would you then be wearing like a mask and everything to change that dressing, like just in case?
Well, wear gloves for sure.
Yeah.
But you have to decide what your PPE would be. If you think there's a chance, if you were like irrigating it, and you think there's a chance for a splash, then I would wear the goggles and the mask. But if it was just a matter of putting a wet to dry on it or something like that, then you don't need a mask. And it's not carried by air.
Mhm.
It would just be, did you think you have a chance of a splash
Okay.
more than anything? So of course, as healthcare workers, you want to maintain your standard precautions. And we think of standard precautions as just gloves, but it's not. Standard precautions is whatever you feel is needed to prevent contracting it. If you're emptying a Foley and you think you might splash it, then put your goggles on. You make sure you have your goggles on. I think probably the two exposures we've had from students to HIV were a known patient who one got urine in her eye and one got breast milk in her eye. She was priming in the NICU, tubing from the mother didn't have breast milk. The mother had herpes. It wasn't breast milk. So they wouldn't give breast milk from a mother that was HIV positive because it's transferred in breast milk. So they wouldn't be given to the baby. But the mother had herpes. And so when we went through this big thing in the middle of the night, trying to figure out what we should do about this. And then when we went to look it up, we found out that herpes is not transferred in breast milk. So we felt a whole lot more comfortable on what we were going to do about it. But so make sure, if you think it's going to be a splash, then you need to wear protection for a splash. Not a splash, then you wear what you feel like you need to wear. Of course, do not recap needles. That's probably the most common time people get stuck is recapping a needle. You want to use your purple and your orange top solutions to clean up any spills and make sure that you're leaving them at the correct amount of time. That's cleaning up. It takes a hypochlorite solution. Alcohol will not kill the HIV bacteria virus immediately, but the hypochlorite, bleach solution will. All fluid is contaminated until proven otherwise, and try not to get blood and pee and poop and out on the outside of a container. Try to keep everything inside of containers. But, just take care of yourself. That's all I can say. Do what you think is right. Do what you're most comfortable with. Now, the HIV test, we start out with what's called the enzyme immunoassay, the EIA. It used to be called the ELISA test. It's no longer called an ELISA test. It's now called an EIA test. And it tests for the antibodies that your body has developed once you are exposed. It takes about 6 weeks after exposure for those antibodies to show up. It has a high amount of false positives, but very few false negatives. So if the test comes back negative, you're negative. If the test comes back positive, it doesn't mean you have HIV. If your test comes back positive, they will then run what's called a Western blot on you. A Western blot actually tests for the virus in your blood. If your Western blot comes back positive, you have HIV. And then the CD4 count, I told you, actually measures your CD4, your helper cells, and they use that more for progression of the disease. You can get HIV tests over the counter, like for urine and for spit. Sometimes it doesn't have to be blood. So there's over the counter testing for people. Again, there may be high amounts of more positives than negatives. So, but it might get them to go to the doctor if it's positive and have a more sensitive test done. We do a holistic approach. Again, we want to prevent it, but we also want to talk about what to do if they are positive. So there's a whole approach to how we care for these patients. Medication is definitely an issue. The medications are expensive. A lot of insurances don't want to cover them. They are usually on a bunch of medicines at the same time. A lot of medicines are not compatible with other medicines. So the list is like, this one's on an empty stomach. This one has to be taken on a full stomach. This one can't be taken within 2 hours of this one, and this one can't be taken within 2 hours of this one. And I mean, the regimen is just like mind blowing, and it's very, very difficult. Plus, the side effects are just tremendous. And people don't like taking them because there is such massive side effects with these drugs. I have had 2 students, and I have permission to talk about both of them. I have permission to talk about all these students. I have had 2 students that were HIV positive in our class. They came in HIV positive. Both of them said they were on meds and they dropped taking the meds and they would never take the meds again. They said the side effects were terrible. I had one student that got a splash in the eye from urine and started on HIV meds prophylactically. And she said she lasted about 2 weeks on them. And she said, I couldn't take them. The side effects were so terrible that she said she could not take the medicines. So we'll talk a little bit about what does that mean in just a second, okay, because of the bad side effects. But you know how when you give an antihypertensive, a lot of people are on more than one antihypertensive. So, you go to give meds in the morning, especially when you're early in your career, and they're on hydrochlorothiazide, and they're on a calcium channel blocker, and they're on propranolol, and they're also on a ACE inhibitor. And you go to your instructor and you say, they're on 4 blood pressure medicines. I can't give 4. And the instructor says, well, of course you're going to give 4. Well, what do you mean? I'm giving 4. And they'll say, yes, but each one of them is working, has a different mechanism of action. Each one of them is working in the body in a different way. You're not giving 4 beta blockers. You're giving 4 different kinds. Well, the same thing happens with AIDS. They're on a lot of different meds that are attacking the body in different ways in the hopes of slowing down replication and prolonging their lives. So they're all called antiretroviral agents because it's an antiretroviral virus. So one is reverse transcriptase inhibitors. You got to have reverse transcriptase in order for the virus to replicate. So they'll put a reverse transcriptase inhibitor. So they don't have this enzyme. So maybe it won't replicate as fast. They also have to have protease in order for the virus to replicate. So they'll take a protease inhibitor. Entirely different. Notice that this one ends in vir because it's an antiviral. They have an entry inhibitor. These were fusion drugs. They really thought this was the cure for AIDS when it came up. This hardens the shell of the cells, and it wouldn't let the virus come out and enter into the cell. They said, oh, the virus is there, but it can't get into the person's cells anymore. And then the virus would just die. And that was going to cure AIDS. Didn't work, but it did slow it down. And lifespans became longer and longer and longer. And then they got the integros inhibitors. And again, you got to have integros in order for this to replicate. And so they've got all these inhibitors going, and it has really slowed it down. They're living longer and longer and longer and longer and longer. We haven't cured it, but people are living longer and longer and longer because we're stopping it. We're hitting it from all different angles, that we are prolonging it simply by hitting it at a lot of different angles. Then they're going to be on the medicines to treat their opportunistic infections. For example, trimethoprim and sulfamethoxazole. That's the drug of choice for the PCP pneumonia. That's Bactrim, by the way, or Septra. It's the drug of choice. Chemotherapy for their cancers, like the Kaposi sarcoma or the lymphomas. Again, fluconazole or the amphotericin B if they've got the thrush or they've got the retinitis or something like that. So they're going to be on other medicines to treat their opportunistic infections. But they're not without their side effects. Diarrhea is a classic side effect. Nausea, pancreatitis, fatigue, rashes. You treat their side effects symptomatically. What do you treat? How do you treat diarrhea? Put them back on clear liquids. Give them Lomotil, give them Imodium. How do you treat nausea? Put them on clear liquids. Give them Phenergan. Give them Ondansetron. Phenergan is promethazine. Give them Ondansetron, which is Zofran. Treat them, their headaches with probably Tylenol, acetaminophen. Teach them don't overdo. Treat their fatigue by getting plenty of rest. If they've got itching, give them diphenylhydramine for their rash. So we're going to treat those symptomatically. Okay. It also can cause abnormal lab values. If their lab values become life-threatening, they got to come off the drug. But it can cause them to have decreased white count. They're constantly fighting an infection. They're constantly fighting a decreased immune response. Their white count's going to fall. Some of their drugs will cause their labs to become abnormal. Okay. I know my time is getting short. And I talked about this just a second ago. So what are their problems? Diarrhea. I talked about this already. Put them on clear liquids. Treat them symptomatically. Assess their how many stools they're having. Altered mucous membranes. The mouth is filthy. They need to get their teeth cleaned at least every 3 months. Soft toothbrushes. Saline rinses. They're going to have bad gums and they can lose their teeth from it if they're not careful. They've got to be very, very careful about that because their teeth can rot out of their heads because they can't fight infections. And in my last minute or so is the psychosocial issues. Anticipatory grieving. There is no cure for AIDS. Okay? There is no cure for what we're going to do. I do have to go back and make another point in just a second. but there is no cure for AIDS. So they got to look at the anxiety, look at the grief, look at the caregiver role strain as you're unable to start taking care of yourself, as you're having diarrhea and you can't clean yourself up. Look at the people that are scared they're going to catch AIDS by coming in and visiting with you, which we know doesn't happen. But people are scared to be with you. People are scared to come to your house and have a drink out of a glass that maybe you drank out of, even though we know they don't catch AIDS from that. But people are going to be scared to come and visit you. What isolation that is, just fear of lack of knowledge and that type of thing. I want to go back to the meds for just a minute. Because of the side effects, people stop taking their medications. Because of that, what has been found with medications is that, people say to me, because I think that's a couple of my next slides, people say to me, what about Magic Johnson? How has Magic Johnson lived all these years? We've known he's probably had AIDS for 30 years. Some of y'all don't know who Magic Johnson is. Magic Johnson says the reason he's still alive and he hasn't converted to AIDS, he's had HIV for 30 years plus, is he had the money. He hired somebody whose job is to make sure that he takes all his medicine on time and never misses a dose. They say the key to living a longer life is never missing a single dose and never being late with a single dose of medicine. If you miss a dose, research says all you have done is for nil. Once a dose is missed, all is lost. So you have to be exceedingly compliant. Now, how do you think that controls your life?
Janie, are there any like studies on how many people like go into AIDS just because insurance has denied their medications?
Absolutely. Okay, so in answer to that, who gets AIDS meds? Because doctors and clinics and you can read different things, especially people that are on this go, that's not true. I work at an AIDS clinic and that's not true. But this is what research shows, okay? Who do we give AIDS medicines to? There's 4 groups that pretty much can have AIDS medicines. There's always exceptions. Number 1, healthcare workers who have been exposed will get medications for AIDS. So you get stuck, you get exposed, we will give you AZT. We will give you a medicine, prophylactic medicine. Number 2, pregnant women that are HIV positive will get meds to hopefully decrease transmission to the fetus. Number 3, patients on drug studies. So you agree to be on a drug study, you will get your meds and you'll get your meds for free. Lots and lots and lots and lots and lots of patients are put on drug studies because of the cost of medicines. Number 4, once you have AIDS, you can have AIDS medicines. You cannot have them before. You cannot have them while you're HIV positive. Why? Because when you're asymptomatic and you feel wonderful, the medicines make you feel like crap. So what do? You stop taking the medicines. Then when you're then when you're AIDS positive, you can't have the medicines because you're tolerant. You've developed a tolerance because you had the medicines before and stopped taking them. So over time, what true HIV doctors have found, true infectious disease doctors that specialize in HIV and AIDS say, while you're asymptomatic, go on. Once your CD4 count starts to drop and you start feeling bad, That's when you're already starting to feel bad. That's when we'll start you on your meds. And then we'll prolong your life then. Because like my two students, like my nursing student, that they say, I'm never taking those meds again. So you got to have compliance. You have to have compliance. Okay, I'm finished. I'll answer questions. I'm not going to give any more content. I'll just answer questions. That's all the content I have, just some slides. That's all.
Janie, I have a question. There was like a practice question about consent for testing. Is that information that we need to know?
No, what did it say? It's like most people consent for testing for themselves, but if a healthcare worker is stuck and they need to draw blood from the patient they were stuck from, the patient does not have to give consent. We can get blood from any patient that a healthcare worker was stuck from. Was that what the question was about? Do you know?
It had something to do with court as well. It was like if it was a court mandated something or other, I think.
If somebody is exposed from a person, that person does not have to give consent to have their blood drawn. But like an employer cannot make you give consent just because they want to know that all their employees are clean. They can't do that. But if you as a healthcare worker got an accidental stick after somebody, that patient does not have to consent to have their blood drawn. They'll draw an HIV, they'll draw a complete hepatitis panel, and they'll draw a VDRL for syphilis. And the patient doesn't pay for it either, but they do not have to give consent. And I don't know what the question is, but they do not have to give consent for that.
I'm trying to find the question right now on the Moodle page.
Any other questions?
Hey, Janie.
Yeah.
So you're in one of the slides, it says it's not transferable through urine, but then you gave an example about a student who got like urine in their eye. I'm just.
Right. But it was after an HIV person. And so they gave her the option of taking the medicines.
Okay, I was wondering.
Now, if that urine was full of blood, then the blood in the urine would be transferable.
Okay,
but they just gave her the option of taking the meds because she was concerned it was after an HIV person. And then when she got sick from the meds, she said, forget it. I'm not taking them.
Okay, thank you. That makes more sense.
Yes. Do you all know, y'all don't know this. This isn't on the test or anything because I told people they could hang up. If you get stuck with a needle from a known HIV person, your patient's HIV positive, we know, or they even have AIDS, we know it, and you get stuck after them, statistically, the chance of you getting HIV or AIDS from that patient is almost none. 0.06% is the national conversion rate for that. Almost none. Never. You'll get measles from your patients before you'll get HIV from a patient. You're not going to get HIV from a patient. Unless you have sex with them. You're not going to get it from a needle stick from a patient. And I hope you're not in bed having sex with your patient. So
I found the question, Janie. It
Okay.
says, the nurse in the emergency department reports that there's a possibility of having had direct contact with blood of a client suspected of having HIV/AIDS. The nurse requests that the client have a blood test. Consent for HIV testing can only be completed when the following circumstances are present. And you guys said the correct answer is a healthcare provider has been exposed to the client's blood or body fluids. Testing is prescribed by a physician under emergency conditions. Testing is prescribed by the court based on evidence that the client poses a threat to others, and testing is done on blood collected anonymously in an epidemiologic survey.
Okay, read the question part to me. The last statement.
Consent for HIV testing can only be completed when the following circumstances are present. Select all that apply.
Consent for HIV testing can only be completed when which of the following? Consent can only be completed when which of the following? Okay, what's the end? Give me the choices again.
You guys said when a healthcare provider is exposed, the test is prescribed by a physician under emergency conditions. Testing is prescribed by court based on evidence of a threat, and testing is done on blood collected anonymously by an epidemiologic survey.
That one. 4's the answer.
It was a select all that apply. So all 4 of those were the answers that you guys gave us.
Oh, I thought it was just one. I know 4 is the right answer.
Yeah, you guys said that all 4 of those were. The one you said that was not the answer was when a healthcare provider who is taking care of a client requests a blood test. You said then it cannot be done.
I didn't say it couldn't be done. I don't know that it takes consent by the patient. I don't know if I understand that question well.
It's the it's question number 3 on the February 6th or February 5th quiz.
I'm coming. I have it right here.
And then there was another one about, it says the client with HIV/AIDS confides he is homosexual and his employer does not know of his HIV status. Which response by the nurse is the best? And you guys said there may be persons that will be privileged to this information. So are we allowed to share that information with people?
No.
So I guess I'm not a little confused as to why that is also the correct response to that question. Like who would be privileged to that information?
We're talking about the
Whoever
doctor.
the patient wants to be privileged to it, or the healthcare workers that are within the need to know it can. But his boss isn't one of them. All right, I'm almost logged in. Hang on.
I'm confused about that one too. The one that
Okay, tell me the first one. Let's look at the first one first. What's the date?
The February 5th quiz, the question number 3.
February the 5th. It's not the 3rd because my grandson's birthday is on the 3rd. So I always know what his birthday was. It's always February the 3rd. The 3rd one. Okay, let me read it again. The nurse in the emergency department reports that there is the possibility, get y'all's pictures out of the way, of having direct contact with blood of a client who is suspected of having HIV/AIDS. The nurse requests that the client have a blood test. Consent for HIV testing can only be completed when the following circumstances are present. Select all that apply. A healthcare provider has been exposed to the client's blood or body fluid. Testing is prescribed by a physician under emergency conditions. Testing is prescribed by the court based on evidence that a client poses a threat to others. When testing is done on blood collected anonymously in an epidemiological, when a healthcare provider who is taking care of a client requests a blood test. Consent for HIV testing can only be completed when the following circumstances are present. Select all that apply.
This question stumped me for a good minute.
When a healthcare provider who is taking care of a client suspects of having a request a blood test. Well, see, when I first read this, I answer it different than the way that when you first read it to me. And I don't know if I'm going to get this right or not, by the way, because I don't have the answers in front of me.
The answers are A through
I would
D.
say A, I would say B, I would say C for sure. Consent can be completed when the following certain testing is done on blood collected anonymously in a That looks like that's spelled wrong. Epidemiologic. Epidemiologic. I think it's spelled wrong. Survey. So I kind of think D is the answer. Because I think it's worded funny, and these came straight out of an NCLEX review book. We didn't write these, by the way. But I think what it's saying is consent can be granted by the hospital, but it's not a well-worded question. I would say A, B, C, and D. Is that the right answer?
Yeah.
Because E means the patient has to give consent. If the doctor wants to order it for the patient to have a blood test, then the patient has to consent to it. If all we want to know is, do you have AIDS for your benefit, then the patient has to consent to the blood test. But the other three, the patient does not necessarily have to consent to it. Those are done whether the patient consents to them or not. Yeah, those are done whether the patient consents. I think the question needs to be reworded. I'll look at rewording that. I think it's just saying that not that the patient has to give consent, but like the physician is giving consent. I think is what it's saying. So it's not a good worded question. Either way you look at it, it's not a good worded question. Now, what was the other one? I can't explain any better than that. But when I read it the first time, I wanted to say A, B, C, and D. And then the E would be that the patient had to give consent versus the other one, the nurse was asking to have it drawn. So I just read it. It's funny how you read it. That would be a tough question. Not a good question. Not a good question.
The February 2nd quiz.
February the 2nd. All right, just a second. I'm trying to get to February the 2nd. Not as easy as you think. February, it's not the 3rd either. February the 2nd. I never could remember my grandchild's birthday, but then he said, JJ, it's February the 3rd. I've always remembered it since then. It's the 3rd of February. Okay. Do you know which one? 1, 2, or 3?
I believe the third question.
Okay. Let me read it. Don't tell me the answer yet. Doesn't mean I'll get it right. A client with HIV and AIDS confides that he is a homosexual and his employer does not know of his HIV status. Which response by the nurse is best? Would you like for me to help you tell him? No. The information that you confide in me is confidential and I won't tell anyone. No, that's not correct. I must share this information with persons that you come into direct contact with. There may be persons that will be privileged to this information. The answer is D, because physicians may need to know it. Certain people in the healthcare system that are within the confidentiality area that needs to be known. There may be people that need to know it. That's the best answer. I don't need to help him tell his boss he's homosexual. I'm not promising I won't tell anybody. There may be people in the healthcare realm that needs to know that. And not everybody comes in. The lady that delivers his tray doesn't need to know he has HIV. Not everybody has to know that he comes in direct contact with, needs to know he's HIV positive. Everybody's HIV positive as far as we're concerned. So there may be persons that would be privileged. Is the correct answer 4?
Yes.
That's what I would answer. The correct answer is 4.
So would like the trip up on this question be like where it's just mentioning his employer at all? Because that's technically kind of irrelevant information for this question.
Well, I mean, I think it's saying that he's homosexual and there's people he doesn't want to know things. So what is your role in that as the nurse? You can't tell him, well, I won't tell anybody because that's not true. So when people have information they don't want told, what is your role as the nurse?
The reassurance.
You can't guarantee them you won't tell anybody. There may be people you don't tell, but you can't say, I won't tell anybody. Because you've got to follow HIPAA, but HIPAA does allow you to tell certain people if it pertains to their care. You can tell people if it pertains to their care. You can tell that. So D's the best answer that sort of addresses that kind of issue. So that's the best answer. I think that they're just trying to get that there's people he doesn't want told. I don't know if I told you all this in class or not, was how easy it is to break HIPAA. In the ER, a lot of patients have to come in through the ER, and if they're pregnant and they're more than 20 weeks, they go upstairs to labor and delivery. Did I tell you all this in class? And so I'm working the triage desk one night, and this woman comes in, obvious pregnant. I mean, big and pregnant. And she, I call upstairs. I tell her, ask her name, all the stuff I got to call upstairs and get them. I get an escort to take her up to labor and delivery. And it's maybe a few minutes later, and this woman walks in, older woman walks in, and she goes, I just dropped my daughter off here, and I had to go park the car. And she said her daughter's name, and I said, oh, we've already sent her up to labor and delivery. And the woman looked at me as confused as could be and said, I didn't know she was pregnant. And I'm thinking, oh Lord, is that not a huge HIPAA violation I just did? Did I not? I mean, it was so obvious this girl was pregnant. And the mother said, I didn't know she was pregnant. I'm thinking, oh, how could you miss it? But she did. She did not know her daughter was pregnant. All she knew was her daughter was having abdominal pain. And I'm thinking, well, okay. I said, well, I'll get someone to help walk you upstairs. They, oh, how easy you can break HIPAA. You can break HIPAA and never mean to. Thinking you're just being nice. You just have to be careful. Okay, who else?
have a question. Sorry, I have a question I just want to clarify. So to be diagnosed with HIV or AIDS, you have to have HIV or be HIV positive, which will mean that the CD4s will be less than 200 because it'll be in the late stages and one of the opportunistic infections.
No, remember I said they only have to have one.
Okay.
So they could be HIV positive and have thrush and have a CD4 count of 1,000.
Okay. So they don't have to have the low CD4.
They don't have to have a low CD4 count.
Okay. Thank you.
I will say most do, but they don't have to have a low CD4 count.
Okay. Great. Thank you.
You're welcome. Anything else?
Thank you, Jenny.
Okay. All right. Text me or whatever. If you text me tomorrow, I might have trouble getting back because I'll be driving for about 3.5 hours, but I'll get back to you as soon as I can. Okay. Because I got to get my shot and drive back to the beach, but I will get back with you as soon as I can. All right. Take care. Call me, text me, whatever you need to do. Bye-bye.